Are we happy to start? Or...
Yeah, please go ahead.
Okay, I was just waiting. Yeah, right. So yeah, thank you. Thank you for the group administrators to allow me to present. And as that mentioned in the group, it's just a very basic presentation, which is starting to use focus for confirming or, in the equivocal cases of necrotizing enterocolitis. And my name is Amitava. I'm a consultant neonatologist at East Lancashire Hospital, a tertiary NICU, as I mentioned, in a non-surgical and non-respiratory setup. So that makes this more interesting and more challenging for us. And this was predominantly supervised and done with me by Dr. Namita, who's a consultant radiologist with pediatric training. I think I just put this out because to make the listeners understand the geographical problems or the issues in Northwest ODN. We are located in Burnley, and the nearest another tertiary NICU without a surgical referral, surgical collocated site is Preston. Now, Bolton, Oldham are all tertiary neonatal units which do not have surgical surgical services. So the nearest surgical services to us and all these centers is essentially Manchester or up north in Liverpool, Alderhay, which basically means that the referral services for any surgical referral are through a central cord bureau, where a conference call is set up and sort of you explain why you're referring, etc. And then it's either accepted or not. And that has been sometimes a challenge because of bed availability and conversations, etc. And more so in cases of NEC, where we have often not had classic perforations, etc. And then we had to have this conversation with the surgical team why we want to transfer. And that led us to develop this skill. So I took a training in bowel ultrasound actually just before COVID with the Canadian group, as I trained there before, and I went in an online course and I did for 8 weeks. And then I worked with Namita and the radiologist group to develop this sort of QI project. So I'm very much a naive person in this starting off, but let us see what we found so long. So as we all heard last talk, which I attended actually, that we know that the radiological standard, gold standard for all of us in diagnosing NEC has been abdominal X-rays, and we know the pneumatocyst, intestinalis, portal venous gas shadow, and perforations are quite significant and sine qua nons of NEC. However, pneumatocyst, the incidence reported in NEC is very varied, can be as low as less than 20% to as much as 100%. And we often, and all of us would agree, have non-specific signs in the initial period, like a fixed loop, which can be precedent to an impending perforation, dilated bowel loops and equivocal, separation of bowel loops and thickening of bowel loops with interloop fluid, which we often see, and we cannot really pinpoint to say what is the exact diagnosis here. The diagnostic accuracy of pneumatocyst has been questioned, though it is a very high positive predictive value, but it lacks sensitivity. And around 50% sensitivity has been reported in literature for pneumatocysts. And you can see this shows sensitivity in PPV for portal venous gas shadow and pneumoperitoneum as well. I want to spend a bit of time on referral to surgical team criteria. And I think that's very important because around 50% of NEC might require surgical intervention. And very recently, I remember Nigel Hall, a consultant surgeon in Southampton, whom I worked with when I was training there, presented data on how the UK referral system is working and why he felt that sometimes the referrals for equivocal cases are a bit delayed because of non-specific signs. And wide variability exists among surgeons in UK with referral criteria. And when there was a survey done by Nigel Hall's group, they found that failure of improvement in maximal medical management was the most common indication for surgical intervention in NEC. And that statement itself is a very non-specific and vague statement, as I understand, because we don't have defined criteria for it. And looking in the literature, I found that there are some literature around what can be predictive of surgical intervention. A fixed bowel loop and clinical worsening, again, another sort of a vague term. Of course, pneumoperitoneum is an absolute indication. Another group found that rising inflammatory markers and lactate levels 72 hours after onset of diagnosis can be predictive of surgical intervention. And the group from Hassani, the latest publication in 2021, found that persistent thrombocytopenia and acidosis with a low serum bicarbonate might be predictive of surgical NEC. Now, when I looked into, a bit of around what is the guidelines in UK for transfer, I found it was again a bit disappointing because besides Northern Neonatal Network and the London NTS, I could not really find any put down guidelines to say this is why a baby needs to be transferred in NEC, in major abdominal pathology. And that too was only London NTS mentioned abdominal ultrasonogram to be useful in certain cases. This basically led me to look at what the ESPNIC group had said in 2020, that FOCUS can be helpful in detection of more than just pneumatocysts. It can be helpful in assessing bowel peristalsis, intra-abdominal fluids, might guide peritoneal drainage. However, it's interesting to note that their statement on necrotizing enterocolitis provided a quality evidence of C, and mentioned very specifically that it has to be performed by a pediatric radiologist or a person with specific advanced ultrasound training, which is, of course, an expertise and skill set to be built up. So that is why we thought we'll look at bowel POCUS. And this is an American publication, but this is the approach sort of we used in our unit when we started doing this. We used the C3, C10 curvilinear probe for the liver and architecture and the portal venous structures. And then we use linear array probe L818 for the bowel architecture. And we scan right upper quadrant, right lower quadrant, left upper, left lower for this. When you look at what we want to find, just before we go to the main scans, we were wanting to see portal vein, and any gas in portal venous shadow can be abnormal, and we'll see a video of that. Free fluid collections, small fluid collections are physiological. However, echogenic fluid collections like complex fluids are quite predictive of surgical interventions, as was pointed out in a recent publication. We can measure bowel wall, and I'll show a video of how we did it. It's between 1 to 2.6 millimeters. Less than 1 is considered thinning, and more than 3 millimeters is indicative of thickening. And thinning is a late feature of NEC, indicative of ischemia, and thickening occurs earlier. We can assess peristalsis, which I found very useful in cases of feed intolerance when the feeds were being stopped, and equivocal X-rays, which is not to be confused with respiratory motion. Peristalsis should be around approximately 10 per minute in a window if you keep the probe there. We can calculate and actually have a good understanding of vascularity. In a square window of 1 centimeter square, if you calculate the number of color signal Doppler dots around one bowel loop, according to Feingold's criteria, around between 9 to 11 colored dots per square centimeter is normal. We can see ischemic patterns where there's very few vascular dots, and we can also see hyperemic flow patterns where there is increased vascularity, which gives rise to well-described shapes like zebra signals and Y-shaped signals. And of course, we want to see pneumatocysts, which is echogenic dots along the circumference of the bowel wall, not to be confused with intraluminal white shadows, which can be fecal material. And these will not change with decubitus, peristalsis, or compression with the probe. So we started this project in 2022 between myself and a radiologist, and our basic aim was not to initially make decisions based on that, because we wanted to basically establish feasibility and efficacy. We basically wanted to correlate the bowel ultrasound findings with clinical suspicion and abdominal X-rays reported independently. And all the logs were kept of scans that were done with concomitant lab values. Basically, as you really understand, for all practical purposes, only 2 people were available to scan and had the wherewithal to scan. So if there was a clinical suspicion and the AXR was pathognomonic, there was no bowel ultrasound that was requested. If the AXR was inconclusive or equivocal, and if we were on the floor and were available, a request was put in, and a formal request was put in through ICE for the radiologist with an indication for the scan. And all scans that were performed by me were reviewed by the radiologist, and she generated a formal report on the EPR. And we kept a log of all the scans and all the indications that people put in. We didn't put the indications. The indications were put in by the clinical team on the floor, which is interesting to see what they were. And then we decided on the final outcome of the scan. Now, if the diagnosis was already confirmed as NEC, in some cases we will see another scan was requested because of, as we were describing, no improvement with conventional medical conservative management. In case of persistent thrombocytopenia and rising CRP, occasionally scans were requested. So we did only, I think 24, this number is actually 24. We did 24 scans, which formally recorded over 12 months. And I just put them on in this for the interesting, I found it very interesting what people wrote down as indications of scan. And these are exactly verbatim what was written down on the radiology request. So most commonly written things were abdominal distension associated with aspirates and raised infective markers. And the next most common was suspected NEC/query pneumatosis. And that was the commonest indication I found among the consultants for referring for that. There were blood in stool, some term babies with pneumatosis, feed intolerances with suspicious abdominal X-ray. There were 2 babies who were already diagnosed and were treated for NEC and had clinical worsening. And one was an unexplained pneumatosis in a well-term infant, which I'll come to. It's an interesting one. We had 7 positive scans. 3 of those 7 scans had non-specific findings on AXR, which meant we did not have pneumatosis or portal venous gas or pneumoperitoneum. All the positive scans, all 7 of them, had higher than normal or rising trend of CRP. Most scans had thrombocytopenia, less than 100 at the time of the scan. But surprisingly, most of the scans had normal lactates when they were done, positive scans. One baby we found portal venous gas shadow, which we could not find in the X-ray in abdominal ultrasound, and I'll show you that. And I'll come to this in a bit more detail. 3 babies were referred for surgical evaluation based on bowel ultrasound when there was no perforation on the X-ray. And one of them had extensive bowel resection, actually. So this is just a normal, all these scans, a disclaimer, are done by me, so they're not the best quality scans. I was just, learning. This is a normal bowel scan with a normal structure of bowel and having peristaltic motions. When you freeze and take a picture, this is how you can, this is the classic signaturing sign where you can actually, which is called the thickening of the bowel or the bowel wall measurement. You can measure the bowel wall and see whether it's more than 1 or less than 1 or more than 3. Classic small bowel loop. This is what a more thickened and a ragged bowel loop might look like, and we'll see a video of that. When we do vascular assessment, we can see circular dots around a single bowel. Now, this was a child who had echogenic foci, and I have a video of this as well, which around the intestinal loops, which were not moving with peristalsis and decubitus change, which could be indicative of NEC. Now, this was a very interesting, I don't know, I can't see anybody's, I can't see anybody actually, but can anybody guess what this is? Any ideas?
Is that the portal venous gas?
It is portal venous gas, yeah. You can see the portal venous gas hyperechoic shadow moving through. I had a very good video of it. I'm so sorry I couldn't get it. It was much more clear actually. But I was quite surprised at this actually to see portal venous gas. Yeah. So this is a normal vascular pattern of a small intestinal bowel loop where you can see normal thickening. If you look at, there are easily more than 9 to 11 vascular dots along the intestine. This is a zebra pattern. Vascular hyperemia, classically described in literature. If you see some pictures in the archives paper, this is classically how it looks like, the zebra pattern. Hyperemic vasculature around unhealthy gut or inflammatory gut. Oops, sorry. So yeah, we'll come to this. Right. There's a few cases. I say it's a small presentation, but a few interesting cases to discuss. This was a preterm 24-weeker. It was a triplet, second triplet actually. It was diagnosed and treated conservatively for NEC with antibiotics, was nil by mouth, triple antibiotics, etc. Currently was on day 4 of antibiotics and CRP was progressively increasing. Was 190 when the child looked clinically worse. Platelets were 20 and lactate was 1.5. When a scan, and the surgical discussion had already happened, and they had said it's just a medical management, what can be offered that you cannot do there? A scan was asked for, and as I said, I really want it to be interactive. I can't see anybody so if anybody wants to shout out what they feel they can see, that'll be great. This was one, and can anybody venture what is abnormal in this scan?
I think, Amitava, I can see a fixed loop floating around a pocket
Absolutely,
of fluid.
like fixed loop floating around and a lot of complex fluid, which is echogenic. And another scan, another picture from the same patient was this. This is a color Doppler and a fixed loop which had signature thumb, sort of printing of a intestinal loop, but had low vascularity, even on low color velocity. There was no vascularity in this cut. And this child had a long resection of bowel. And thankfully, when we spoke to surgeons, and then radiologist herself said that I have scanned, reviewed the scan, I think that there is complex fluid collection and avascularity. They took the baby. The baby is now going home with stoma. A stoma has been reversed, I think. So this is one interesting finding I found, and I was really glad that the child could be referred. I'll come back to this actually. This is a 27-weeker who was diagnosed with NEC, had completed an antibiotic course for NEC on day 27 of life. From day 27 to day 49, this is a very recent infant actually, had multiple episodes of abdominal distension and feed intolerance, stop, start, antibiotic courses. And day 49 had a raised CRP 52, platelets were 99, lactate was 2.9. Abdomen looked distended, nothing to go by. This was the X-ray done on the same day. I could not really, put my finger on anything pathological, and we can have a discussion around these X-rays and etc. So this was a scan picture. I think this came in a very different format, but please shout out if you see anything that is abnormal in the scan.
The bowel walls look a little bit thick, but I'm not an expert on it.
Yes, the bowel walls were thick. There were fibrin strands, and there were left side was actually okay. Right side was the problem, and there was collapsed strands and collapsed bowel loops, bowel thickening, fibrinous strands and fluids.
It looks like you have some hyperechoic areas just within the bowel wall. I think you were on the right. I don't know.
This one?
Yeah, a little bit there on the bowel wall on the top, like a 5 o'clock.
There are more than 9 to 11 dots. But I could not obviously see any. I could not see any. What should I say? Pneumatosis in this scan. But my impression was that this child had quite a lot of thickening of the bowel. There's fluids in the complex fluids in the abdomen. I could not rule out any collection or strictures. After a lot of discussions, baby went. And they had a laparotomy, did not find any evidence of NEC, but had very, very prolonged feed establishment, had Broviac lines put in, eventually was established on pump feeds. And they couldn't really point out why it took so long. They went to Liverpool actually, and has just come back to us on pump feeds. And it's been a very long journey for this little one. This was a preterm, 26 weeks, yes, was now day 48 of life. And they had 3 episodes of abdominal distension with suspicious X-rays, repeated episodes of feeds being stopped and multiple courses of antibiotics. This was one X-ray, this was another X-ray. Again, there was stippling on the left side, could have been fecal material. There was some dilated bowel loops. And the baby, when I scanned this baby had been stopped on feeds and was on antibiotics, and that was the X-ray actually. This was done just a week earlier, I think. This was the X-ray. And anybody would find anything abnormal in the X-ray? Like, would you be concerned with the X-ray?
Left upper flank.
Left upper flank, yes.
Yeah, maybe some pneumatosis there.
Exactly. So we don't know. It can't be. I couldn't pinpoint it. This was the scan. This was left. This was left upper quadrant. Typo there. And you can see normal gut mobility, normal peristalsis, and actually normal vasculature, and lots of fecal material inside the lumen actually. This child's scan was completely normal, and the X-ray normalized after and was established in full feeds. And we could stop antibiotics in 48 hours time because the cultures were negative. And this was a normal scan actually. Allowed us to sort of, yeah. This is a 25-weeker IUGR. He was a severe BPD actually, ventilated 37 weeks. This is a very interesting one. He fully fed on EBM, was growing. Our main concern was with ventilation. It was like very high ventilation pressures, steroids, etc. Was introduced high-calorie formula for growth. Abdominal distension happened 48 hours into formula introduction. There was blood in stools. I remember the weekend being called in for blood in stools. CRP was high, lactate was completely normal, platelet was normal. These were the two X-rays. Any comments?
Bad.
Yes. Well, it looked pretty bad actually to me. And I thought, well, very unusual at like this age of life. Why would the child have NEC, etc.? But it didn't really look at all bad, the child. It looked clinically absolutely fine. These were the scans. No evidence of NEC actually. Normal vascularity. Some areas showed a bit of thickening in fluid. No pneumatosis. This child went on to have several episodes of intolerance to calorie. It was thought to be a CMPI actually, and never had anything growing on blood cultures, never needed more than 48 hours of antibiotics. But whenever, I still haven't really put my finger on it, whenever, at least twice when formulas were introduced, he blew up his tummy and had blood in stool, etc. So ultimately was put on NeoFOCUS and went home on NeoFOCUS actually. So one ultrasound I couldn't find. I don't know why I couldn't find it. It got lost in the scan somewhere, machine. But this baby is unfortunate 23-week baby who was singleton, day 6 of life, was being treated for sepsis, stable ventilation, was having progressive metabolic acidosis from the day 6 of life in the morning. And the CRP had raised 37. Lactate was suddenly jumped to 10. And platelets, which were 100, had fallen to 50 and then 11. Was the consultant on the floor had asked me, can you just see what was going on? I wish I could share the video, and I regret not having the video. I was quite shocked when I put the scanner on and I found that the baby's bowel did not have almost any vasculature. There was no colored dot signals I could see almost throughout his gut. Minimal, almost avascular short bowel loops and no peristalsis. Completely static gut almost. Probably severe sepsis causing ileus, probably an early NEC. We never knew because the child developed significant metabolic acidosis and actually had to be withdrawn or reoriented by the end of that day. He became so severely sick with multiple inotropes. But it was a very, what should I say, remarkable scan that I could not share. And that basically is a limited presentation that I had. Very few patients, as I said, very initial experiences, but I thought it will be interesting to just share. So thank you so much, and I'm happy to. I can't answer too many questions, but I'm happy to discuss.
That was a really amazing presentation. Really interested in the images they have showed us, because we have so many patients that you know, like your last example, the classical image of a baby that suddenly you have a gasless X-ray, and you never know, is it perforated, is it? I mean, I was actually going to ask if you had seen any fluid accumulation in the ultrasound that you couldn't show us. Because it's one of those things where you do the X-ray, you see nothing essentially, so you can't really comment much, isn't it? It's so difficult. And in the case before that, that kind of enteritis, I think we have been seeing them a little bit more often, isn't it? They on the X-ray sometimes they do look like, or maybe it's developing neck, but it's just the timing is not right, and then it resolves just by maybe 2 days of nearby mouth. And that entity of enteritis is something that I don't think we have the tools at the moment to identify it and diagnose it properly. And maybe ultrasound is one of those things that will actually add that extra layer of knowledge that will allow us to kind of discern between a beginning of a neck or an enteritis, where we can be a little bit more relaxed about. So really, really powerful tool, ultrasound, in this context, and I'm sure there will be more coming in the next months and weeks and years in learning how to use ultrasound in the neonatal unit. So thank you so much for sharing that.
Thank you, Anna.
I was actually really curious about, you were talking about sorry, I got interrupted by juniors asking me questions. So you were talking at the beginning about how you got the training done on using ultrasound.
Yeah, it was through an online module, and Yasir would know it very well, because I actually approached Yasir through an email some time back to ask for a second refresher. It was Yasir's colleagues who had done a 4 or 8 week online course, and some people from Dubai, to a couple of people from UK and Southampton, we attended the online module. I think it was peri-COVID or pre-COVID, I don't remember, something like that. Pre-COVID, definitely, yeah. But it was a good module where we got to share our scans and get back to them online, so they could sort of comment on it, their initial scans. But unfortunately and surprisingly, I've not actually seen, I don't know if you guys have seen or not, I've not seen good online courses or modules on a lung ultrasound. I see one every week. I literally one every week. Everybody is
really trying to push that.
Yeah, but I don't see any course on bowel ultrasound. I think the last PS, the NeoFOCUS Canadian group had done a 1-day course, and after that I have not seen.
And how does that work in your trust, from the point of view of, I guess you have also discussed that with the radiologists in your trust, or you know, from the governance point of view, and how you're using this tool in the context of your unit?
I think I'll be very honest with you. It's individual, like many things. If a person is, you know, happy with this X-ray and doesn't want to, I mean, I cannot. We have not come to the point of actually convincing everybody that you have to ask. Like echo is a standard procedure now. You have to ask for an echo if you're, you know, multiple inotropes, etc. People generally do that, and because there are 6 or 7 of us who can do functional echo, it's easily available on tap. I think this is more of, you know, if I'm on the floor, somebody said, can you have a look? And initially I didn't comment or did not, for the governance purposes, I did not comment or make a decision on that. I had to wait till this radiologist, who actually has a protected time, thankfully, for our unit, and could come and we review scans and comment on them. And only when it didn't really, you know, it's not ideal, because you want a point of care scan to be commented on point of care at that point of time. You don't want to wait for 3 hours for the radiologist to see it on PACS and then report back to you. But that's how it had to be done initially. I think as we grew in some sort of confidence and very, you know, obvious things, like everybody could see fluids or dead, you know, avascular loops, fixed loops we could comment on. But it's still it's a long way to go, I think.
Yeah, but it's a fantastic starting point, and I really hope that I mean there are a few people in this new focus group that are interested in the use of ultrasound for the assessment of the bowels and possible diagnosis of NEC. So it would be fantastic if we could put our minds together and start writing maybe just a short protocol, if you want, just to give everybody a basic understanding, mainly just to trigger more enthusiasm in going and looking for courses and learning this tool.
Yeah, absolutely.
Hamad?
So I think Ajit got
Yeah.
Ahmed, go ahead if you want. I can wait.
Oh, it's okay. It's not a question because Amitava mentioned Yasser, so there's something about forthcoming things. So you go ahead with questions.
Yeah, Amitava, thank you so much for sharing your experience. I mean, clearly you can see the superiority of ultrasound to conventional radiography and how it's changed the course of management. I had a few questions, and one of that was in relation to training. I did touch upon it, and I just sort of wanted to get a feel of training in terms of, I know you said you had to share cases. Roughly, how many cases did you sort of have to do before you sort of felt confident? I know you're probably still learning as you go along, but to sort of start to get the ball rolling, how much would you sort of consider?
I honestly don't know the answer to this. I mean, I still don't feel confident, first of all. Absolutely not. I'm much more confident commenting on an echo than anything else. But I think every scan that I did, I would wait for Dr. Namita to come and have a look and do a full bowel scan initially too, so that I've not missed out anything. Like when you do functional echo, you want the structural echo to be done before that. So almost all the scans I requested her to sort of come and look at it. All I can say is that after 24 we logged, I think I've done around 50 scans. I can at least, I have an impression of what is a healthy bowel, which is an unhealthy bowel, if that makes sense. Like I can say that this bowel looks healthy. The commonest cause now I see people calling or asking for a scan is that I have stopped feeds. I'm a little iffy about this abdomen. X-ray is not showing me anything. Should we stop feed? Should we give 5 days of antibiotics? Like, we don't want to miss that. And I think if the bowel is peristaltic, vascularity is normal, and there is no complex collections, so we have been able to reinstate feeds. That's the only thing I can say, honestly. I have a big, I think one of the big deterrents is gas in the abdomen. I find windows very difficult to get if it's very distended. Second of all, infants get very uncomfortable if you're trying to push the probe. If it's actually a tender abdomen or is inflamed. So I actually provide them swaddle, or if she's already on morphine, a pre-morphine bolus, which is also, I do not want to sort of go ahead and do and I many times have to back out because they just can't tolerate it. So it's a big deterrent. Echo, I don't think none of us would say that we can easily get some views quickly, even if the child is very sick. But I have found it quite difficult if the child is very sick to get this sort of images sometimes. So yeah, as I said, I'm very much a learner, very much a beginner, and as more people do it, I'd like to do more stuff and learn together, I guess.
Yeah. No, that's. I think one of the good things is your colleagues do feel that you have the necessary skills to inform their practice, and the very fact that they're asking you sort of to do the scans is actually a good sign that you're getting better and better at it. And I think the radiology support that you have does help as a fallback on. I had another question also. I know you mentioned these 24 scans that you've done over a 12-month period. Roughly how much are you doing to sort of per month to sort of keep up your skills?
Last 2 months, I think I did 3 or 4.
Okay.
Honestly, there is no, that's a question I want to ask myself. And that's why I said I don't find any training courses, refresher courses that you can go and, do another course.
Yeah.
Unless you do multiple courses, and there is so less out there. I'm pretty sure that we need to, that much noise we have to make that this is a good tool, and we need to have more courses who can sort of train us. And I do think that the radiology team needs to be involved in this training as well. It's not only neonatal people who can train us. The radiology team needs to be also involved in the training process, actually.
No, thank you so much. Thank you so much for sharing experience.
No, thanks.
If I can just come and comment on the training and courses. So first, that was a fantastic presentation. Thank you so much for sharing your experience. It's amazing. And I really loved that you have a structured approach to scanning and you're collecting data. So that's really good. I'm sure the more you do, the more you get more kind of feedback and stuff like that. So Yasser, of course, you know that Yasser has been doing this for many years, and he built a fantastic experience. He shared in the last presentation about crashing infant protocol some comments that it might take 1 or 2 years until you are actually competent in doing this in relation to giving like clinical advice and making changes in the management. And because it's not easy, to be honest, to get decision making, is that NEC or not, is the baby needs to go to OR or not, you know, it's not easy, but it's a learning curve like anything. So I'm hoping we'll do some collaboration with Yasser to give us a talk and possibly come and give us some hands-on session next year as part of our kind of conference activities that we do every year. So
that will be very helpful. I think that will be very helpful if there's a workshop which happens on, you know, hands-on. And
Mahmood and Amitava, can I come in? So Amitava, first of all, yes, a fantastic presentation. Really, thank you very much. Umayma is here, and I found out yesterday that Yasser is happy to go ahead on 5th of January to speak about abdominal scans on our Friday meeting. So I have yet to personally confirm this with Yasser, but if Umayma says that should suffice. Yeah, so I would we will all be looking forward to Yasser speaking up here on our forum. The timing might not be 12 because 12 in UK is something like 5 in the morning for him. So once I get the timing finalized, which I mean a little bit more humane for somebody in Canada to speak, and then we'll share the information and I'll let you know the date and time.
Okay, that's great. Thanks, Arun.
If there's no question, Amitava, can I ask a question?
yeah, sure.
So to my understanding, for decision making, you're still almost completely reliant on the radiologist. Is that correct?
Well, yeah, I mean, she basically thinks that I can comment on it, but I think there is a process there. I just cannot go ahead and make a formal report because of governance issues. The formal reporting is done by the radiologist. But as I said, I can provide some clinical judgment to my colleagues if I can get good images. I mean, it's still a process of where it needs to be ratified by the radiologist. Yes.
So does the radiology people they bring their machine and probe, or is it that they use?
We have the machine in our machine only, and as I said, this is done by one pediatric radiologist. So it is very much a service which I don't see a future in unless people get trained and there's funding or a business case made for it. Because I think we all know that how difficult it is to have, you know, at least in our trust, the radiologists cover 2 sites, which is again a geographical problem. So sometimes they can have to remotely report. Sometimes they're here. If I have pulled favors to ask her to come on site quickly if she's there around and review a scan. It's a bit of a, you know, still a very informal asking favor stuff, how it started off. But we have presented it to the radiology department and we have said that this is what has happened and can there be some protected time for the neonatal point of care scanning by the radiologist who is trained and more cascade training. So I'm hoping in the next 2 years it would happen, but I think right now it's still a very, very primitive structure. Is what I like to say.
You mentioned the most common question about abdoscan from our colleagues and ourselves, that can I restart the feeds? So so that's essentially a very bedside thing, where it's a very point of care thing.
Yeah.
And you don't have time, and that's not exactly the occasion for getting a radiologist in.
No.
Because that's when you're talking surgery and stuff. So how often do you? You said just 3 scans in a month. How often do you counter this?
Well, I think we only can scan when there's a scenario for that and you're asked, isn't it? We really have to depend on what the clinical request from the floor is. But as I said, I have that much I can say, that it's that much confidence of, I mean, it's too early, but I think I've understood to discern out a healthy and unhealthy cut. And if there is no massive red flags and people have just stopped feeds for just aspirates or slight abdominal distension on a baby who's on an IV, etc., we can scan and say, we can start feeds safely. There is no sign. As I said, there's difficult, more complex babies which require radiology input, definitely. But I think that much we can generally we can comment on, or we do comment. I do comment on. Again, as I said, it's completely the consultant on the floor's decision whether he wants to have a scan, whether he wants to act on that, or it's completely. It has to be his head on the. The buck stops with the consultant on the floor, actually. So yes.
Great, thank you.
Thank you, everybody. Thanks, Mahmoudan, for arranging and allowing me to speak. I'm very grateful, and I would really look forward to more talks on this in future, and or any collaboration that happens on bowel ultrasound.
Brilliant.
Thank you.
Thank you very much.
Take care, guys.
So much.
Thank you very much.
Bye-bye. Have a nice weekend.
You too, everybody.
Bye.
Bye.